Yo, yo, yo. Hey, guys. Welcome back to another awesome edition of the Best Practices Show podcast. Number one, thank you for showing up. I am having so much fun doing this. And I'm going to keep bringing it with great speakers, great new rock stars in dentistry on hot topics. And my team finds some of the best people anywhere. And when it comes to the subject of pain and how important it is when you're taking good care of patients, I found a great, actually I didn't, my team found a great rock star, Dr. Mary Charles Haigler. And today she shares with you some great thoughts about why you should learn more about orofacial pain being a specialty and its role in the future of dentistry. It is awesome. So check it out. Hope you guys enjoy it, and we'll see you guys soon. Hey guys, welcome back to the Best Practices Show podcast. I get the fun, the excitement, the cool job of being a CE junkie and finding all of these rock stars in this great country, in this great world of ours, in the great profession of dentistry. And I get to interview them and bring this information to you to create a better practice and a better life. And I've got an amazing new rock star in dentistry in a new specialty, Dr. Mary Charles Haigler. And we're going to be talking about orofacial pain as a new specialty. So Mary, thanks for being on today.
Thank you for having me. I'm excited to be here.
Yeah, and you're like, I don't even know, how does this work? Don't worry, we're going to have some fun.
Don't worry, I cheated and listened to your podcast before coming on.
So you did? Okay. So you were completely underwhelmed before you got here, so this is all good. But I want people to know who you are. You are the only licensed orofacial specialist in South Carolina. Is that correct?
That is correct as of now. So South Carolina orofacial pain only became a specialty within the last couple of years officially. And so I had to kind of go to the board of licensing in South Carolina and ask them, can we recognize this specialty? And so then they did approve it, and then I had to apply for it. So I'm the first one that's actually applied and gotten the license here.
Yeah. Congratulations.
Yeah. Well, thank you.
Yeah.
Thank you.
Yeah. And so talk about this trend, because before we hit the go button, you said, it's a lot of education, helping people understand what this is. And so how important is this aspect of dentistry? And let's talk about the why behind it and how you see that.
Well, there's the why of why I got into this field, or the why as to why it's important.
Both.
And I think they both overlap.
Yeah.
So for me, I did practice general dentistry from about 2006 to around 2015. Along the way, I think we talked a little bit earlier about being CE junkies, and the more I learned, the more I wanted to learn. And then the more I realized that the way I practice is I like to listen to my patients and take time with individual patients. And I'm not a very good room hopper, like a lot of general dentists end up being. And so I went through a variety of continuing ed, and then I ended up with going to a lecture that Henry Grimion was putting on. And he's pretty well known in the orofacial pain community, to say the least. And so from there, I did a continuum with him in orofacial pain at LSU. And then I guess I'm a slow learner, and I just decided I needed to go get a master's in it too. So I went to the University of Southern California's program to get a master's in orofacial pain and oral medicine under Glenn Clark. And so the more I learned, the more I realized there was to learn. And then since I've become a diplomat of the Board of Orofacial Pain, and I'm practicing orofacial pain out of it's funny, if you look for me, I'm at an oral surgeries practice. So I'm with a bunch of surgeons treating orofacial pain, so not surgical at all. But I guess the way I have learned is that there's so little information in the general public about orofacial pain that I've taken on trying to inform other people. So I have residents from MUSC, which is the Medical University of South Carolina. Well, dental students come and rotate through so that they can learn a little bit before going out. And so that's why when your team asked me if I would be on here, I was like, well, that would be great, because we need to let people know what orofacial pain is about.
Yeah, I love it. My team is always like, no, I promise you, like, you got to I'm like, awesome. And it's amazing how they find all of these great up and coming influences in dentistry. And there's no question you're doing that too. And when you talk about the patient side of things, you and I were chatting about this, you know, the TMJ, TMD thing has been put in, disorder's been put in one bucket. They just think it's like one thing, but it's not. Can you explain that?
Right. So patients will come in and they'll inform me that they've been diagnosed with TMJ. And so I have to tell them, well, let's break it down a little bit more, because there can be either a disorder that involves the articular disc being out of place. There can be arthritis, which can either be osteoarthritis or an autoimmune condition. There can be muscle pain or myalgia. There can be a combination of those, or they can be separate. So it's trying to figure out exactly what that patient has going on. So then we can tailor the treatment or the management to whatever symptoms they're actually having.
Yeah. And so there's a whole range of classifications, you know, and I just learned that about even gluten. So I have a sister-in-law who's got celiac. She's like, no, it's not one thing. Like, there's a whole range of classifications, and just figuring out, getting as close as you can to figure out what to do next. Is that kind of the same thing? I mean, a little bit of the...
That's kind of the same thing. It's kind of like, so basically I'll take a history from the patient. You can learn a lot just from hearing what the patient has to say. Even if they don't fully know what's going on, they can still tell you, well, when I open, I can only open this wide now. I used to click and now I don't. All of those are little key words that tell you maybe it's a disc disorder.
Right.
Or some patients will tell you that they have other joints that are achy and painful. And so then that kind of clues you in. So just getting a good history helps to start the process. Along with that, I look for comorbidities like mood disorders, anxiety, depression. I look for sleep disorders such as obstructive sleep apnea, because those things can be correlated to jaw pain as well. And so we like to look at the whole picture, the whole patient, to try to figure out the best treatment for them. And then, of course, there's the exam itself, where we use palpation, auscultation with stethoscopes, different things to try to figure out exactly what's going on. And then the fun part is educating the patient and making them understand what's going on in their body so they can help to manage what's going on.
Yeah. And now I'll say this to the people that are listening. Like, if you guys have been listening for a while, you've already heard us say this a million times. I believe this, but I want to ask you, Mary, if you believe. Dentists are more positioned, more than any other healthcare professional in the world, to help people be healthy. I mean, you're looking at things way at a much deeper level than probably anybody. I mean, we're biased here, but like, tell us your thoughts on that.
Well, I agree that we do have that opportunity, because in dentistry, I feel like a lot of us have the opportunity to make our own schedules the way that we would like to, where as in a lot of the healthcare professions, they have maybe 15 minutes with a patient and they only can really focus on one thing. To tell you the truth, with a new patient, for me, I plan to spend about an hour and 15 minutes with that patient. So in that time, I have a good chance to get a lot of history and to then take multiple pieces and say, well, you know, you have this elevated pain level, but at the same time, it may be related to, we'll give you just an example. If your sleep is disrupted, then that affects your body's ability to regulate different neurochemicals, neurotransmitters. So then that affects your ability to modulate pain. it also puts you at risk for other types of disorders. So looking at the whole patient helps you to be able to, I'm not going to necessarily treat every part of that if they have hypertension or they have a mood disorder, but I can help them to get that treatment, which then helps us to get them well.
Yeah. And another thing that you're really passionate about is the referral patterns between muscle and teeth and finding out where the pain is, because it's much more complex than what we used to think 20 years ago. Can you speak about that?
Well, it is. And, I've heard people say, well, I'm concerned about working with these patients because sometimes they come in and they'll say that, or some patients will come in and say that they have a tooth that hurts, and you look at the tooth and there's nothing wrong with the tooth, but they're convinced that it is. Well, that could mistakenly lead to a practitioner thinking that the person's either making it up, trying to get something done that's not needed or get medicine that's not needed. But the reality is that in a lot of those cases, they do feel pain in a certain tooth, but the pain's just not coming from that tooth. There's a discrepancy in the site versus the source of the pain. So there's a pretty well-known referral pattern, and I learned it through Travell and Simon's referral. They have charts that show you, if you say, for example, if I put pressure on the sternocleidomastoid, that muscle may be painful where I'm putting pressure, but it also might make the patient have a tooth that hurts or have their forehead hurt, or and they'll be very confused for a moment. They're like, how did you just make my headache worse? And I'm like, well, that's because that's where the pain's actually coming from. It's just where you're feeling it is in a different location.
Yeah.
And the same thing happens with the teeth as well. So the masseter can refer to any individual tooth. So that's why I like other dentists to be aware that if a patient has a toothache and I know you're trying to help them, but if you don't see anything wrong with the tooth, just kind of step back and try to reassess.
Yeah, this is amazing. And you're finding out exactly where the pain is. Going back to the whole point, like diagnosis is really, it's so crazy important finding out where to start, because there's multiple treatment plans, but only one true diagnosis if we figure out what it is. But you're just asking the right questions.
Well, and anybody can if they know the question to ask. We can only do what the best we can with what knowledge we have. And so that's why I feel like it's really important for the orofacial pain community to reach out and reach out to dentists, reach out to ENTs too, because a lot of patients will have earaches that are actually pain from the temporomandibular joint as well.
Yeah. And then I would love for you to talk about this with interdisciplinary dentistry or even dental communities. Is this well received? I have a special place in my heart for specialists because they have to work really hard. It doesn't matter what specialty to create value for the rest of the, dental community. But has it been a challenge to really be recognized as a specialty? And if not, why not? So, and if so, give us some perspective on that.
So I think there was a little bit of a challenge to get the specialty recognized. And I think part of it was because general dentists can do a great job with a lot of these patients. And so I think some people worry about, if there's a specialty, does that take away their ability to take care of them? And the answer is no. If you can do a great job taking care of patients, then you don't necessarily have to refer out. We're just here to help with the more challenging ones, or patients that maybe don't fit the traditional mold. Or, some people may be perfectly comfortable treating patients that have myalgia or muscle pain, but may not feel comfortable treating a patient that has arthritic changes to the joint. And so I think orofacial pain in general can, even within the TMD category, doesn't necessarily mean that we're trying to take it from general dentist or take it from somebody else. It's just, we want to help to get the patients the care that they need.
I love it. And what do you think most people get wrong as you're talking to them about orofacial pain? Like what What do you say? No, it's not. That's not true. Or,
Well, the funny thing is with orofacial pain, it's not, I know I've mentioned TMD a lot because that seems to be the biggest overlap with general dentistry, but orofacial pain also, we manage pain that's related to the joint, but also it could be within the mouth. It could be headaches. It could be things in the region. So there's also neuropathies, neuralgias that we help with, headache disorders. Also, because of the overlap with sleep apnea and especially the appliances, if we're able to use a mandibular advancement device in someone with a TMD, that could be needed we might need to manage it a little more carefully. Mm-hmm. And so we do also help with obstructive sleep apnea management as well. So I think one thing is just that it's a broader area than just TMDs.
Yeah. And I'm always curious the impact of, not so much COVID, but recent, it just seems like patients are under more stress now than ever. Or, it's not like wear is going away. It's not like perio is disappearing. And, right. I would imagine sometimes people describe these pains that are phantom pains or, I even have phantom feelings. I feel like my cell phone's buzzing in my pocket when it's not, it's really wild. And so from a dental perspective, do you feel like people are experiencing more pain physically? I know, it just seems like it is, and maybe it's not. I don't know.
Well, it does seem like, to be fair, I've seen uptick in my practice, but then again, I finished my specialty in 18, 19 I joined this practice, so 2020 is, as my practice is building, is also when all the stress from COVID and everything really kicked in. So I have seen an uptick, but I might be a little biased just in how my practice has progressed as well. But I do think that stress does increase. It's another risk factor for different pain symptoms. And we do know that there is a relationship between anxiety and depression and pain modulation because they're both controlled with serotonin and norepinephrine. And so if those are out of balance, then people can have more difficulty suppressing pain signals as well.
Yeah.
So yes, people that experience anxiety at an elevated level may be experiencing more pain, even if it's not just the muscle tension that is referring that pain as well.
Yeah, it makes perfect sense. Now, you're obviously very passionate about this movement. And so, again, we have a lot of dental students listening. Tell me what the future of this looks like and why I might want to consider it, as a future if I'm a dental professional.
Well, I think as more people learn about this specialty, there's going to be more and more need for the providers. And to be honest, there are just not very many orofacial pain specialists out there. So if you wanted to get involved, I feel like there would be an easy turnout for you to have there's plenty of patients that have pain. So I think that that's important to know. Another part that I like about it is I feel like it's a different opportunity than a lot of the specialties in general. So for me, I like that it's kind of like a little problem solving. It's like a little mystery that you get to figure out what's going on. And so that intrigues me and it helps me to stay interested. But the best part is you may have a patient that comes in the first time you meet them. They've been to several places before. They're a little pessimistic. They're not feeling well because they're in pain. So they're a little irritable. And as long as you remember that you're here to help that person and you really listen and you really try to help them, when you see benefits that they're having, say at a post-op, when they're feeling better, even if you don't get all the pain to diminish, but it's helping them, you can tell a change in a person's whole outlook and their demeanor. And that's probably the most rewarding thing, is just to see that you're making a difference in someone's life.
Yeah, I love it. I love it. And, the preventive side of things is always so much fun to talk about. I want you to talk about this. So yesterday I had Tom Viola, who talks a lot about pharmacology. It's very, we're so quick as a country to write a script for things. If we just understood what was happening, can you talk about the role, proactively diagnosing these things versus the challenge with pharmacology, or even prescription medications, like with what you're talking about?
Well, so there is, pharmacology does come into play a lot of times by the time a person sees me. But a lot of times it's not necessarily narcotics or pain medicines of that category. It's more of anti-inflammatories. We may need some muscle relaxers until we get things calmed down, but also just teaching people home therapies, which are things to increase blood flow, help them to keep their range of motion, help them to learn how to not clench all the time, maybe give them an oral device for nighttime use when they can't control clenching. Little things like avoidance of hard, crunchy foods, things that they can take with them to help to manage really go a long way. But pharmacology is needed, but I think one misconception is that opioids are the answer to pain.
Right.
And for these patients, for chronic pain, it really can make things worse,
Right.
make the pain more intense. So to be honest, I don't really go that route as a general rule.
Yeah.
So
Yeah, and you're super smart. I'm not, and so the reason I say that is so I'll just tell you a quick story. So last week I have this thing in my back, and so I've got a younger dentist who's around here. He's like, it has nothing to do with your back. That's your hips. I'm like, what are you talking about? He's like, it's related this. And he gave me like 4 stretches. It was amazing. He's like, I want you to do this. I want you to do this. And so this pain that was in my deep middle back was killing me. I started doing these yoga like stretches that he was right. And it went away like that. I'm like, oh my gosh, where I might have gone home and taken a leave or something like that, or put but the whole idea of systemically understanding how the body works and its forces on each other component, he just said it over and over. It's your hips. I'm like, it doesn't hurt here. He goes, but it's starting there. And so I think what you're doing is amazing, really diagnosing where all of these things are coming. And I have to believe it's a little bit of a moving target. Like you're always learning about things.
I am. I do, and I love to keep learning. And I've almost thought you meant the pain itself can be a moving target, but it is always something new to learn as well. So I can kind of talk about both of those. But the patient sometimes doesn't have pain in just one place. So like if they have true arthritis in the joint, then that pain can cause their muscles to try to splint and protect it. So then they can have muscle pain and joint pain. And to go with your hip story, sometimes posture. So if we're working on a computer all day and your forward head press position, that puts a strain on your neck, changes your airway. So then that can also affect the positioning of the jaw. So everything is related. So it's all one body. So we kind of have to, that's why we try to look at the big picture of things. And then, as you said, the moving target, the CE is always coming out. There's always new information, new understanding of the mechanisms of why things happen. And we talked a little bit before the camera started rolling. I love some CE. I love to sit and learn. And I think that's how I got in this field, just wanting to understand more. And it kind of is a little bit of a selfish reason too. With general dentistry, for me, I didn't listen well enough in the ergonomics section of school, and I would lean over probably more than I should. And I have neck problems as a result. So sitting in that position I can understand pain. And so that empathy for people having painful disorders, I think, is a main reason why I'm in this field too. I want to help other people so that they don't have to have that feeling as well.
Amen. There are way too many young professionals that we see that have pain way before they should. And I'm like, you're 35. You should not be having this pain right now. And it is crippling in some facts. Like so I think it's so important. I have Uchi Odiatu on here quite a bit, and he's like, the power of movement, and like he's got us even breathing, like, on how important all of those things are. I want you to go back to the moving target of CE too. So I can't remember a time where it's been so exciting to talk about so many facets of dentistry. And I would imagine in orofacial pain, it's just cascading into, we're learning more and more. I had Steve Carstensen on, and he's an amazing dentist that's really an expert on airway. And he was going to do a lecture this week. He's actually doing it, I think, today on the nasal cavity. I'm like, Steve, you're a dentist. He's like, no, this stuff is so fascinating. And what we're learning now is just cascading into other things that help us better understand how the body works. And is that true in orofacial pain from an education standpoint?
Oh, of course. So like I mentioned, we're learning about neuropathy, neuralgia in the mouth, so different nerve conditions. We also are learning all the time about more information about migraines. A lot of us are also members of the American Headache Society, so that we can understand the migraine patterns, because migraines are also a condition of the trigeminal nervous system, which we know is also what gives us the pain signals from the face as well. So a lot of times when their patients are having even a TMD type of pain, that pain could be a trigger for a migraineur or a person that gets migraines. So just keeping up with what's going on in other fields is also very important.
Yeah, this is so awesome. Any last thoughts you have on orofacial pain as a new specialty? Any last things you'd love to say about it?
I would just love to encourage people to find out more. And one little thing that I can't go without saying is, if you have a patient come in and they have pain and it's an intense pain, just as a little final story, I had a patient come in one time who was having a toothache. The toothache started the night before, woke her up in her sleep. She went to her dentist. He's like, I'm not seeing anything. I'm going to send you to the endodontist. Endodontist got her in the same day. Endodontist looks and he's like, something's not right. And he sent her to me, and I'd had a cancellation that day and I got her in. Y'all, this never happens all the same day, but it did this day. The patient came in and I didn't see anything on the x-ray. I didn't see anything looking in her mouth. I did all my palpations that I normally do. Couldn't find any reason for it. I realized the patient was nauseated as well, completely fatigued. She thought she was just feeling poorly because she was in so much pain. But to get long story short, there is an acronym called SNOOP that stands for systemic, neurologic, onset of pain, and then there's the how old the patient is it progressing, is it persistent? Anyway, all these different things. But if you look at those and something's out of whack, so she was having systemic signs, sudden onset of pain, she was over the age of 50. All of those things told me she needed to go to the ER. And the lady was having a heart attack and had 3 stents placed that night or that day. And she presented because she had a toothache. So my whole point in telling you this is, if you can't find something wrong with the tooth, step back and see what else could it be.
Wow. That is a life-changing, it's amazing how you were able to help somebody in that respect. That's frightening, actually. It's crazy.
It is. It is frightening, because the truth is that a lot of times I don't get people in the same day. Mm-hmm. And so I believe that I don't know if you believe in miracles or things like that, but I think she got to where she needed to be that day. She got to the ER that day.
Yeah.
And I think there was something beyond my control there.
Oh yeah. God's always looking out for me every day. Like, I don't always listen, but like, you better believe there's somebody else
Yeah.
Making some things happen here. That's for sure. But I am so grateful to have you on. This is awesome. And I also want people to follow you, find out more about what you're doing. Our writers will put all of this together. So Mary, where can we send them? Like, if I want to learn more about this, find out more about what you're doing, where do I go if I'm a listener?
So the American Academy of Orofacial Pain, which is the AAOP, has a website. The American Board of Orofacial Pain, which is the ABOP, also has a website. If they want to reach out to me, you'll find me I think I mentioned earlier, I actually work with a bunch of oral surgeons. So the easiest way to find me is through Carolina's Center for Oral Facial Surgery, which is mycenters.com. And that's the easiest way to find me.
Awesome. Well, thank you so much for being on. I really appreciate it.
I appreciate it. Thank you for having me.
Yeah, that wasn't so bad, was it? Like,
no, that was fun. That was fun.
There are some people that come, they're like, I'm not coming up. I'm like, why? They're like, I'm like, I promise it'll be easy. And so,
not at all.
I think education should always be fun, a little insightful and helpful. And so you did that today for sure. So thank you so much.
I tend to stumble a few times, though. I caught myself a couple of times.
I stumble more than anybody, so don't sweat it. Don't sweat it at all. So good stuff.
Well, thank you so much for having me.
Yeah, we'll stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. Like I mentioned, all of our writers, it doesn't matter if you're listening to Stitcher, iTunes, Spotify. If you flip up to the show notes, you'll see everything that Mary mentioned. We have a link for it. So you'll be able to click on it. That'll take you directly there. So the cool thing about this podcast is we take notes for you. How cool is that? And so we're going to make your homework easy. I'm going to encourage you guys to check it out. And anything else you guys want to see, please reach out to us. I'll have Mary back. We'll ask her the tough questions and we'll do it that way. So thank you guys for listening. And until we see you guys next time, or you hear from us next time, keep watching the Best Practices Show. You guys have a great day.